We will move on to Sylvia, who is a PhD student in health and rehab sciences, and she'll be sharing her research today on nutrition concerns and lung disease.
Okay, so I've attempted to keep it to 15 minutes. I'll see how that goes. We're taking a little bit of a different detour. So as Kendra said, so I'm defending my PhD in health and rehab sciences, focusing on health and aging. And I'm also a registered dietitian. So I've focused more on kind of nutrition concerns and disease. So I'll be taking you through my PhD dissertation. I was co-supervised by Dr. Jason Gilliland and Janet Madill at SPhA. So for my presentation, I'll start off with giving a brief background about the disease, nutrition-related concerns, and a systematic review that we completed. I'll take you through my research objectives, the methods of how we obtained these objectives, and go through my key results just for for time. And I'll end with our conclusions. So I'll begin by discussing interstitial lung disease, followed by reviewing nutrition-related background. So interstitial lung disease, or ILD, is a chronic and progressive lung disease with over 100 separate disorders that fall within this umbrella term of ILD. These disorders have varying degrees of inflammation or scarring of the lining, or known as the interstitium, of the air sacs of the lungs. This results in altered gas exchange, which means that oxygen and carbon dioxide are not transported as efficiently through that scarred lining. And this negatively affects a person's ability to breathe. So ILD is classified as a rare disease, and in Canada, it affects about 42 in 100,000 Canadians, and its occurrence increases with age. Unfortunately, without medical management, prognosis is poor. And aside from pharmaceutical treatment like medications of the disease, patients may be on supportive oxygen to help their breathing. They might participate in physiotherapy to help improve muscle strength and function, or they may be recommended to lose weight to help improve their ability to breathe. Unfortunately, when medical therapy fails, patients may need to be assessed for a lung transplant, and in Canada, a significant portion of lung transplants, about a quarter to a third of transplants, occur in patients with ILD. So I will review some nutrition-related concerns and implications on the disease. So as the ability to breathe is affected in ILD, therefore the exercise capacity or a person's ability to participate in normal activities of their daily life, so for example, cooking, cleaning, walking up a flight of stairs, can also be negatively affected. In ILD and many other chronic lung diseases, the medical community uses something called the 6-minute walk test in order to evaluate exercise capacity. And this involves essentially having the participant walk at a comfortable pace for 6 minutes total, and the resulting distance is measured in meters. As mentioned previously, exercise capacity is affected by the altered ability of the lungs to transport oxygen and carbon dioxide, but can also be affected like decreased muscle mass and strength, also affected by poor nutrition and or weight. And when we consider weight, both underweight and overweight can result in difficulty breathing. So for example, when participants or patients have significant weight loss, this can result in muscle loss and deterioration in lung function. Whereas in overweight or obesity, breathing is complicated by increasing the effort required by the lungs to breathe. So many patients participate in pulmonary rehabilitation, which is a targeted program aimed to help improve exercise capacity as well as quality of life of lung disease patients. Generally, these exercise programs include aerobic exercise, strength and flexibility training, as well. There is mentioned to be a nutrition component as part of pulmonary rehabilitation. However, specific guidelines, recommendations don't include any specific supports or recommendations for the needs of nutrition in this patient population. And as well, there's a big research gap as there's no current studies in ILD that has actually tested the potential for nutrition interventions to improve exercise capacity. What we do know related to nutrition is mainly focused on BMI or weight. So BMI is our weight standardized for height or divided by our height squared. And interestingly, in ILD, it's been found that survival time is actually longer in individuals that have higher BMIs, especially those in the obese categories. However, it's widely understood that BMI doesn't give the best overall picture of health, and it overlooks a component of the important contributions of body composition, like muscle and body fat and bone density. So, more recent research within ILD has started to focus on body composition. And not surprisingly, results have shown that the amount of muscle mass, regardless of BMI, better predicts survival in patients with ILD. So that is that fat-free mass index, which is the amount of lean body mass, or all the components of the body aside from your fat mass, and then standardized for height, so divided by our height squared, is associated with longer survival times regardless of BMI. So in other words, it doesn't matter if an individual has a lower amount of body fat or a higher amount of body fat, as long as they had sufficient muscle mass, their survival time was significantly longer. So one method that we can use to determine body composition is bioelectrical impedance analysis, or BIA. So with BIA, essentially a battery-powered current travels through the body, and as that current interacts with various tissues of the body composition can be estimated. There's different types of machines and formats. What we used in this research was the Bodystat 1500 MDD, which is a multi-frequency current that travels through one side of the body. So it goes from the hand and the foot, and then is doubled to estimate the other half of the body composition. It's important to point out, though, that these are estimated values. So we're not actually measuring body fat or muscle mass like we would if we were measuring our weight and stepping on the scale. However, there are other variables or values that are generated from BIA, which are actual measures, known as phase angle and impedance ratio, which are determined based on resistance and reactance of the current and the ratio of the impedance of different frequencies of the current. So these measures are thought to be potential indicators of various outcomes. So it's been used as disease severity indicator, survival, and also an indicator of nutrition status in the literature. Limited research, though, exists actually verifying these as appropriate indicators of nutrition status. However, having an objective measure of nutrition status is appealing, as it may be used to identify patients at nutrition risk when skilled clinicians are not actually available to complete hands-on nutrition assessments. So therefore, we aim to determine if phase angle in particular, because there is a larger body of research related to phase angle compared to impedance ratio, if phase angle is an appropriate indicator of malnutrition in disease by completing a systematic review, which was published in Clinical Nutrition SPhA. So in order to most appropriately assess the utility of phase angle in nutrition assessment, we compared it to the gold standard within nutrition assessment known as the Subjective Global Assessment, or SGA. So the SGA is a simple bedside assessment which combines nutrition and disease history along with a physical examination which aims to identify signs of muscle loss, fat loss, etc., and combines all these to determine a category ranking of either A, B, or C. So SGA-A indicates a person who's well-nourished, B indicates moderate malnutrition or being suspected of being malnourished, and SGA-C indicates severely being malnourished. Conversely, so phase angle is an objective measure, so it's not influenced by the examiner. It's thought to be a measure of cell health. So a higher phase angle indicates healthy, intact cell walls, while a lower phase angle indicates poorer cell health and an altered ability of the cell to perform normal cell processes. Therefore, the theory is that malnutrition, which can cause alterations at the cellular level, can also be identified using phase angle. So we searched through numerous electronic databases to identify research articles that included both phase angle and SGA. Ultimately, after screening 286 articles, we ended up with 33 articles that directly explored the relationship between SGA and phase angle. So these 33 articles included 4 main diseases or conditions. So liver disease, hospitalized patients, cancer patients, and kidney disease, including both those that were pre-dialysis and those that needed dialysis. Overall, we found that the quality of evidence using grade guidelines was low. In certain conditions, especially hospitalized and cancer patients, the quality of evidence was moderate due to stronger relationships between that phase angle and SGA. However, overall results were limited by varying strength of relationships from study to study and disease to disease. As well, many studies used different cutoffs in order to classify patients as either well-nourished or malnourished, so it limited our ability to compare between studies. Therefore, further research is needed to be completed to properly validate phase angle as an accurate indicator of nutrition, for example, within a lung disease population. So that leads me now into reviewing kind of the research that we did for my PhD dissertation. So I will start by reviewing what my specific objectives are. So given the gaps in the literature that I identified related to nutrition concerns in ILD, we aim to complete 4 main objectives. So we wanted to first determine the prevalence of malnutrition and to estimate body composition. Second, we wanted to evaluate how nutrition status and body composition were related to exercise capacity. Third, as no research currently exists examining BIA objective measures like phase angle or impedance ratio in ILD, we wanted to see if it was an appropriate indicator within this disease population. And lastly, we aim to add to the body of research and examine if body composition and nutrition status could independently predict survival. So how exactly did we achieve these objectives? So we recruited 78 adult participants from an outpatient respiratory clinic in London, Ontario, and collected a variety of data at the time of their clinic visit. We reviewed their medical charts for height, weight, specific diagnosis of ILD, results of lung function tests or breathing tests that they complete as part of their usual visit, their exercise capacity or their 6-minute walk distance results, and other relevant data such as oxygen use, smoking history, date of diagnosis, other comorbidities, etc. And then on the date of recruitment into the study, we completed a BIA analysis to measure body composition and determine their SPhA score. So my key results. So what did we find? So my first results paper focused mostly on our exercise capacity outcome and those indicators of nutrition status. So the majority of patients were moderately malnourished. The smaller portion of them were severely malnourished, just under 8%. We were able to classify patients into 4 main body composition groups. So we have normal sarcopenia, which is essentially low muscle mass, obesity, which is normal muscle mass, but excessive body fat, and then sarcopenic obesity, which is an interesting one where there is excess body fat on top of inadequate muscle mass. So these patients can be hard to assess from the naked eye because we don't see those telltale signs of muscle loss and wasting because that excess body fat is essentially masking those. So they can be a hard one for us in clinical practice to identify. Also, when we compare or collectively look at the sarcopenic and sarcopenic obesity, almost or a little bit over a quarter of patients had inadequate muscle mass, so fairly clinically significant. So what did we find when we looked at exercise capacity? So we examined how muscle mass and nutrition status are related to exercise capacity, which was measured using that 6-minute walk distance. So we assessed muscle mass using a fat-free mass index Z score. So if we recall, the fat-free mass index is the amount of lean body mass divided by height squared. And then we calculated a Z score, which if you remember back to if you took a stats course, this generates a value that is comparable to a healthy population norm. So for example, a Z score of 0 equals the population average. A negative Z score would be below that population average, and a positive Z score would be above that population average. So what we found is that for every 1 unit increase in a participant's Z score, we would expect them to walk 16 meters farther on their 16-minute walk test, or 6-minute walk test, sorry. Similarly, we found that with each improvement in nutrition status category, so for instance, if an individual with severe malnutrition compared to moderate malnutrition, so an SPhA of C versus B, we would expect that patient who was SPhA B to walk 68 meters farther than that individual that was an SPhA of C. And the same for comparing SPhA of B to A. So for both of these, we did control for different factors such as lung function, and we found that both of them were independent of lung function. So even those that had poorer lung function, as long as they had adequate muscle mass, they still walked farther than those that maybe didn't have as much muscle mass but had better lung function. So fairly significant that we found that it was independent of their lung function or their disease severity. When we looked at our objective measures, we also explored the relationship between the phase angle and impedance ratio versus nutrition status. Not surprisingly, based off our results from our systematic review, there wasn't a relationship between phase angle across the SPhA categories. However, with impedance ratio, which is the ratio of the impedance of the current at two different frequencies, which we also controlled for age and sex using a Z-score, was related to severe malnutrition. So we found that a worsened impedance ratio Z-score increased the odds of an individual being severely malnourished as opposed to being well-nourished by 276%. So potential results that support its use as a nutrition indicator. And my second results paper focused on the survival outcome. So we looked at muscle mass and nutrition status again, and we assessed the same using the fat-free mass index Z-score and SPhA, and we found that improved muscle mass using that Z-score was positively associated with survival time. So in line with previous papers that have been published in this area. So that is, in other words, for every 1 unit increase in the Z-score, the risk of death decreased by 33%. And this, again, was independent of lung function. So whether someone's lung function was poor or moderate, it still was an independent predictor of survival. And similarly, in looking at nutrition status, individuals with severe malnutrition had a 7-fold increase of risk of death compared to their well-nourished counterparts. Interestingly, we didn't find any difference between well-nourished and moderately malnourished. Only between the well-nourished and the severely malnourished was there an increased risk or odds of death. So although our study was limited by the sample size, which limited some of our abilities to run some statistical tests, especially in those subgroups when we kind of slice and dice and put patients into different groups, that limits our numbers to be able to compare. Despite this, though, there appears to be a relationship between nutrition status and body composition and an individual's exercise capacity and their survival with this disease. So this first highlights the importance of nutrition assessment in monitoring an ILD patient populations, and it secondly warrants further exploration into the complex needs of this patient population in order to investigate, for example, how targeted nutrition interventions may help to improve exercise capacity, quality of life, and disease prognosis in these patients. There's a wealth of opportunity for new and novel research in this patient population, looking at different methods of body composition analysis, for example, using CT scans or ultrasound. Therefore, it's important that nutrition clinicians continue to be involved in ILD research in order to ensure that ILD patients receive best care in the management of their disease. So I'll end with thanking some key partners and stakeholders. The Lung Association of Ontario provided us with some very valuable funding through my PhD journey. I had a wealth of amazing volunteers from Brescia that helped me with recruitment and data collection. And of course, the team at the clinic at London Health Sciences Centre that graciously invited me to be involved in their patients' care. And lastly, of course, all of the participants that I came in contact with that agreed to give up their time, let me ask them lots of different questions, kind of poke and prod them with all my different tests and assessments. I'll be forever grateful to them. Thank you. Any questions?
I'll just come in with saying that was a great job. I really loved your slide display too. I thought that was great. All your imaging.
I was trying to find kind of the fine line between going into too much detail or not enough detail versus overboard. So I kind of struggle sometimes with thinking I'm too oversimplifying things, but I wanted to try to keep it to that 15 minutes.
Yeah, it came across very well.
Thank you.
Okay, I'll ask some questions. What do you think the biggest limitation of the study is? And, you know, and if you had more resources, how would you overcome that limitation?
I would say just simply the biggest was it was time consuming in that we got 78 patients in our survival analysis. I technically have more than that data collected, but because it was time consuming to go into clinic in the fact that it was only one morning a week, and there's only so many patients that are at clinic a week and not all of them are able to consent, or do we have time to actually see? We were only really able to recruit maybe an average of 3 participants a week. So it takes some time to even get to that 78 participants. Plus with survival analysis, we were only able to include that 78 participants because we did a 2-year survival analysis. So based off of when we ran our analysis, we had to go back to 2 years prior to that. So it didn't include people that we had recruited since then, just simply because of time and logistics was kind of the biggest limitation without being, or to be able to run all these other tests and control for all of these factors. So I didn't really talk in the slides, but we were only really able to compare for one factor at a time, rather than putting multiple different potential confounding variables into control for our analyses.
So it sounds like the only way to really overcome that limitation would be to have lots and lots of money and duplicate you and your team across multiple hospital sites across the country.
Yes.
Or do a 12-year PhD.
Yes.
Okay.
And not every city has a specific ILD clinic. Like there's different hubs. London is essentially the hub for Southwestern Ontario. So we'd have participants driving from Windsor, some driving from Owen Sound to come to clinic. So again, the time constraints, if they didn't want to stay that extra, it was about 20 minutes to a half hour. If they wanted to get back on the road because they needed to get to another appointment or had other plans, that limited their ability to participate in the research study. So there's not many even clinics in Ontario for these opportunities. So it would be a big undertaking to do kind of a multi-site study, that's for sure, with personnel and support and equipment as well, because we did have specialized equipment.
Okay, thanks. Any other questions for Sylvia?
I'll ask a question. Hi, Sylvia.
Hi.
It's Gina. I really enjoyed your presentation. I thought it was well organized. I think it's really impressive, especially what you were just talking about, how much resources had to go into collecting data that you got that many participants for that time span. Mm-hmm. But I'm wondering, given that you couldn't control for some important confounders, what do you think would be the most important confounders you would control for if you had more participants, and why?
That is a good question. I wouldn't say there'd be anything additional that I would add to the study. I just think that if we had more participants, we could control for multiple or more variables in our analyses. So for example, when we looked at survival analysis, I could only do nutrition status and lung function. I couldn't add in then was 6-minute walk test or was exercise capacity. Did that influence survival on top of nutrition status and lung function, or were certain medications affecting their survival? So because there's a whole slew of medications, we didn't have big enough groups across even medication subtypes, diagnosis subtypes, to control and see if there's a difference between different medication use or different diagnoses between or within ILD. So we had everything that we could use to potentially control confounding factors. We just didn't have the numbers statistically to do so. And that's why I tended to focus on that Z score, because that, instead of then comparing sex differences, because if you know anything about male and female bodies, we have different norms of body fat and muscle mass. So we can't necessarily compare them all in one group. So the Z score takes out the sex differences, takes out that age potentially even BMI differences depending on that population data that we're basing it off of. So we focused a lot of the Z scores just to be able to pool more individuals into the same groups and not kind of have to divide and create smaller groups for analyses.
Awesome, thank you. Good answer.
No problem.